Good afternoon, everybody. Welcome again to one of the IO webinars. Most of you know me. My name is Katie Griffiths. I'm delighted to have with us today Tim Allardyce and Clive Lathy, who are going to talk you through shoulder rehab and for online consultations. Now, we've had a slight technical hitch in that we won't unfortunately be able to see Clive. He is dialing in today, but we have Tim with us, and we should be able to see Tim's screen for the presentation. Depending how we go on time, we will see if we can take some questions at the end, if that's all right, Tim and Clive.
Yeah,
sounds fine to me.
Excellent. So, Tim, when you're ready to share your screen, and Clive, please introduce yourselves, and we'll get the webinar started.
Okay, let's just try and share my screen. So I will bring that in now. Here we go. Okay. So you should all be able to see my screen now. If there's anybody that can't see my screen, please put it into the chat or the questions, and then we can go from there. It's fantastic to be speaking to you guys again today. I'm not sure. Can we share video at the same time as sharing the screen, Katie?
Yes, we can see you and the screen, Tim. So we've got both of you. Yeah.
Oh, fantastic. Okay. Okay.
Oh, you can see me? No.
Unfortunately not, Clive. I wish we could, but we can hear you. So that's fantastic.
And Clive, can you see the screen and the webcam as well?
Yes.
Perfect. Okay, great. Well, it's brilliant to be back again talking to you guys. And today's seminar webinar is really about rehabilitation of the shoulder. We're going to talk about some concepts of shoulder rehab. We're going to run through some exercises, some programs. We're going to utilize Clive's amazing knowledge, not just in general rehab, but obviously his amazing sports experience. And I love doing these things with Clive because he just knows so much. He knows so much more than me. I can just hide and let him do most of the talking. So
not true.
So my experience is really about I have worked very closely with shoulder consultants. I'm a bit of a I love shoulders. I treat a lot of shoulders, and so I work with a lot of athletes doing shoulder rehabilitation. I do a lot of post-surgical shoulder rehabilitation, and obviously I'm heavily involved in exercise prescription and rehab. Clive, maybe you can talk a little bit about yourself.
Yeah, thanks, Tim. Hopefully you can all hear me. Sorry you can't see me. My computer doesn't want the webcam to work for some reason. But like Tim, I also work with a lot of shoulder consultants. So I'm also involved in the rehabilitation of shoulder problems, but I tend to send them to my physio team. But I'm aware of the kind of protocols and what the sort of pathways are. So we deal with all sorts of different shoulder problems, sports related and non-sports related, probably a bit like Tim.
Great. So let's talk about shoulder pain. I'll just give you a quick overview of shoulder pain. It's fairly prevalent. It's in fact, it's incredibly prevalent. I don't know about you, Clive, but I look back sort of when I look back 20 years ago, and I never saw as many shoulders as I do now. They just seem to be so much more common than they used to be. Well, they're now affecting about 2.4% of patients that present to their GP actually present with a shoulder pain. So and there's about 300 million GP appointments per annum. So that's a lot of patients seeing GPs for shoulder problems. And about 70% of shoulders are related to the rotator cuff. Clive?
I think I talked to a shoulder consultant about this, and I think there's an increase in non-traumatic shoulder problems, mostly as a consequence of sedentary life and increased time spent in fixed postural positions. And I think you're seeing a lot of very slow burn problems that are developing because of muscle asymmetry, upper cross syndrome, and other cumulative type injuries. But I'm like you, I'm seeing more shoulder neck syndromes than I ever used to. When I first went into practice, I saw a lot of lumbar problems, but I would say that shoulder and neck syndromes are on a par, and I'm sure it's down to laptops and iPads and iPhones, and everyone's in this flexion posture, and you're getting adaptive muscle changes over time. So yes, I agree with that. I'm seeing a lot more.
It's now the third most common musculoskeletal complaint, which is interesting, because it was always sort of backs and then sort of backs or knees and backs and necks, but now shoulders are really coming through, aren't they, Clive?
Yeah, definitely, and as I say, quite often in tandem with cervical spine problems. So you quite often have concurrent syndromes, and obviously from a clinical diagnostic point of view, you need to sort of be able to differentiate and be sure that that you're not dealing with referred pain. But obviously, we'll come on to that further down the presentation.
Absolutely. The big news in the world of shoulders is probably the 2018 Lancet Report, which is a very, very interesting read. They took shoulder pain, surgical shoulder pain patients over, I think it was about 4 hospitals, and I believe I read it a couple of years ago, so I can't quite remember. I think it's about 400 patients they looked at, and they actually did a sham surgery. I'm not sure how they got that through the ethics. But they did a sham surgery and found out that there was limited clinical benefit to doing shoulder decompression surgeries. It really shook the orthopedics world quite heavily, as a lot of shoulder surgeons were sitting back going, wow, I mean, we do these routinely, these decompression surgeries. Now, shoulder decompression is the most common form of shoulder surgery. It's where they go and they trim a small piece of bone underneath the acromioclavicular joint. They just widen the subacromial space. They sometimes trim 2 or 3 millimeters off the end of the acromion, called an ACJ excision, and they remove the osteophytes under the AC joint. It's pretty widely done, but there's quite a lot of evidence now sort of suggesting that those surgical procedures are not actually that viable when you compare them to actually rehabilitation. Is that your experience, Clive? What do you find with that?
Yes, I think a bit like routine arthroscopic surgery on the knee, these sort of clean out operations to sort of trim away pathologies, that we know now that the same thing applies to knees, that actually a rehabilitation program, if it's well constructed, can produce better or comparable results with the surgical approach. And certainly in the shoulder, I know from my own experience, I had a calcified subscapularis tendon from rugby days 100 years ago, lots of wear and tear in the shoulder, and I was faced with having a subacromial decompression. The problem is, what the surgeons don't tell you is the procedure all sounds straightforward, but the rehabilitation is very lengthy, probably 3 to 6 months. And I chose to do a rehabilitation approach instead of a surgical, and touch wood, it was a great decision, and I've not had any symptoms since. So I have seen many patients who, faced with decompressive subacromial decompressive surgery, have chosen the rehab route and physio route and actually been symptom free. So I agree with you, and that study does confirm that. That's absolutely, it's not always the best approach.
Yeah, my personal experience is there's definitely a place for shoulder surgery. Usually when all else fails.
Absolutely,
and that would be really, really useful. So it's still worth keeping good friends. We used to invite our shoulder surgeon for lunch and pizzas and stuff.
Yeah.
He was.
The point is, quite often our physio team have done prehab rehabilitation in preparation for surgery, and sometimes patients become symptom free and decide to postpone the operation, much to the surgeon's annoyance. But I agree. The surgery is obviously indicated in certain cases, but you've got nothing to lose quite often if the patient's symptom free enough to do rehabilitation, to give that a go first anyway, whether you have surgery or not.
Yeah, absolutely. So let's talk a little bit about some shoulder pathologies. So probably the big one out there. Now it comes under a few different names, so it does cause a lot of confusion. But we're really looking at this sort of subacromial pain syndrome, shoulder impingement syndrome. So what sort of experience do you see with patients with this sort of problem, Clive?
Well, in the younger patients, I see quite often traumatic injuries, tendinopathies, sometimes it's things like subacromial bursitis. In the older patients with acromioclavicular degenerative joint changes and osteophytes, you see a more gradual progressive impingement syndromes, whether it's bursa related or thickening of the supraspinatus tendon, or a combination of the two. Yeah, so depending on the age group, you either see in the younger age group tend to be more trauma related, and the older age group it's more of a micro trauma accumulation of pain. But I see quite a wide ranging age groups.
Shoulder impingements very much, it should really be considered like an umbrella term. And the reason that it's an umbrella term is, and this is why subacromial pain syndrome has become has become quite widely used as a potential diagnosis as well, is that it's not a true diagnosis. It's a bit of a shortcut, because actually impingement and subacromial pain, it all kind of relates to a number of things that can cause it. So there's lots of things that can become impinged, or if you follow this line. Generally, things that come under this category are things like the supraspinatus tendinopathy. So the supraspinatus tendon runs right underneath the acromioclavicular joint, and that can become quite inflamed and swollen. And when that happens, it can become irritated, and that can create more inflammation and swelling, and that can cause quite a lot of pain, which restricts your shoulder mobility. And of course, there's a bursa that protects between the tendon and the acromioclavicular joint, so you can get subacromial bursitis. You can have osteoarthritis of the acromioclavicular joint. That's probably the biggest cause of shoulder impingement and subacromial pain syndrome. So when that joint becomes osteoarthritic, you tend to get hypertrophy around the joint, so it tends to get bigger, and this creates osteophytes and thickening of the joint, which then sort of can catch the tendon. And it's interesting, when we look at shoulder MRIs, we often see that osteoarthritis at the actual glenohumeral joint is pretty unusual. We don't see it very often. I've probably seen about 500 MRIs of the shoulder, and we often see hypertrophy and osteoarthritis of the acromioclavicular joint. It's probably one of the biggest predisposing factors to shoulder pain and acromioclavicular pain. But we rarely see glenohumeral joint osteoarthritis. And that might be one of the reasons why we actually also rarely see shoulder replacements done, and why we much more commonly see decompression done. So osteoarthritis, it tends to go to the AC joint much more commonly, and that causes a lot of problems. And it's why our non-traumatic shoulders tend to be of an age group above the 50 years old, 50, 55, 60 years old. So let's look at a little bit more the tendon. And when that tendon gets irritated, it tends to sort of, the theory is that the tendon tends to catch or rub or get impinged under the acromioclavicular joint. There are some people that don't actually agree with this, but I kind of get the idea, I get the concept. And once that tendon starts to get irritated, it can actually fray the top of the tendon. We actually can see this on MRI, so you can actually see the superior surface of the supraspinatus tendon becoming frayed. Now, eventually that can lead to a couple of different problems. It can lead to calcification. If there's enough tendinopathy, it can sometimes, the body says, hang on a minute, I'm going to lay down some calcium and try and protect that tendon. Or it can actually cause if the tendon gets frayed, the fraying can then develop into a partial thickness or full thickness tear. So here you see the osteoarthritis around the acromioclavicular joint, and you can see how it can potentially irritate the tendon, and the typical movements it tends to irritate. We tend to find on examination that internal rotation, abduction and flexion tend to be most affected. Clive, how do you tend to examine for shoulder impingement, and what sort of things do you tend to look for?
Well, if they haven't come through the diagnostic sieve and had MRIs and ultrasound scans confirming the pathology, then I kind of rely on Hawkins and NEAR tests combined with, obviously active and passive functional testing. What I was going to say about impingement syndromes, something that I think is quite interesting is it doesn't take it only takes 1 to 2 millimeters of uncontrolled glenohumeral translation. If the glenohumeral joint is not sitting central in the glenoid fossa, then and there is a tendency with modern life to spend a lot of time in that flex position, particularly using pec major and pec minor. You get this adaptive shortening, and you get the shoulder dragged forward into that slight anterior position. So that increases the chances of subacromial impingement syndromes, particularly when you start bringing your arm above 90 degrees. So yeah, I once I've done all the clinical testing, and I'm fairly sure that the pathology is and the pain is coming from the subacromial space, then I sort of plan the treatment accordingly. And dependent on, sometimes I'm involved with the orthopedic consultants if I think they might benefit from ultrasound guided injection if they've not responded to manual therapy and rehabilitation. But very often it's a combination of manual therapy and specific rehabilitation exercises, which we'll obviously come on to further in the presentation.
Yeah, absolutely. Looking at the acromion, it's quite interesting. And Maria has just asked a question about, can you tell us a bit more about a hooked acromion? So with a hooked acromion, you typically get 3 types of hooked acromions. You get sort of, well, actually, you typically get, well, technically, you get a normal one, which is a flat acromion. And then you get type 1, 2, and 3 hooked acromions. So the hook is essentially, hopefully you can see my webcam, so I'll just sort of demonstrate that that's a flat acromion, that's a type 1, that's a type 2, and that's a type 3. And the hooked acromion, essentially, they believe that it can become hooked from a traction of one of the acromioclavicular joint ligaments. Actually, some believe there's actually a genetic predisposition as well to a hooked acromion. But what they do believe is a hooked acromion does significantly increase the prevalence of rotator cuff issues with the superspinatus and impingement syndromes. And when sometimes radiologists, when you actually read an MRI of a shoulder, they'll actually talk about a down slope in acromion, and that's a very similar thing. So the acromion can be hooked or down sloping, which effectively means that the space beneath the acromion is reduced, and so that's when we tend to get our rotator cuff issues, our superspinatus, rotator cuff impingements. So let's look at rotator cuff tears. So rotator cuff tears are pretty common, and as Clive alluded to, you've got your sort of 2 main categories of rotator cuff tears. You've got your acute traumatic tears. Can happen in any age, but do typically tend to happen in older people where the rotator cuff tear is where the rotator cuff is naturally sort of degenerated, and these typically happen after a fall. So patient comes along, they trip over, they can land on an outstretched arm, they can land on the side of their arm. I had one patient, one lady, she was holding a handbag, she tripped, she fell, and she ruptured 3 rotator cuff tendons because her handbag got caught under her shoulder and it just pulled the shoulder at such an angle it just split 3 tendons. So they can be traumatic or degenerative, and sometimes both actually. I mean, degenerative are more common. So the superspinatus tendon just gradually weakens over time, over many years, and the tendon gets thin. It's not a thick tendon like it is when you're younger. It thins out, it loses some blood supply, and it atrophies. And the tendon doesn't have the integral strength that it did before. So the tendon's more likely to split or tear or to fray. And that's when you have your partial thickness tears, which is a tear that goes through partially through the width of the tendon, or a full thickness tear where the tear goes through the full width of the tendon. Now, it doesn't mean the whole tendon has ruptured. That's actually something else. That's a tendon rupture. That's what you see on the MRI here. So you can see a large gap where my mouse is. Hopefully you can see my mouse. This is the end of the superspinatus tendon that would be attached where this sort of white inflammatory line is here. The tendon's actually ruptured off, and it leaves this absolutely characteristic gap full of white fluid. And they're very much, depending on the age of the patient, they're very much usually sent to the consultant surgeon for a surgical opinion. If the patient's obviously of an age where the tendon is just long gone and there's minimal chance of reattachment, then they'll just be going through rehabilitation. If you've got any views on rotator cuff ruptures, Clive?
Yeah, I think whether to operate or not operate depends on many factors: patient expectations, what they, whether they play sport or not play sport, age group, whether they've got any comorbidities. They don't, as you said, you can live without a supraspinatus tendon. Your deltoid muscle just ends up performing the abduction movement, but you will lose some of the finer control of the glenohumeral position. And that can then lead to other syndromes further down the line. But the decision to operate, say if there's more than one tendon rupture, then it tends to push you towards surgery. But I've seen plenty of older patients where the surgeon decided that the benefit, risk versus benefit, was that probably that you'd used a conservative approach to manage the shoulder and not have surgery, because there's although the surgery sounds quite straightforward, the recovery is quite long. Surgery, and quite often you get complications like adhesive capsulitis forming afterwards. So you've got to bear in mind that the rehabilitation can be quite lengthy, and for an older patient, it may not be necessary to have surgery. But it all depends. Unfortunately, these days there are 70-year-olds that are very fit and active, and they obviously don't want to stop playing sport. So it depends on the patient's expectations and requirements, I think.
Yeah, and talking about adhesive capsulitis, that leads us very nicely on to our next on our next slide, actually. So adhesive capsulitis or frozen shoulder is interesting. It's what can you tell us about adhesive capsulitis, Clive?
Only that I when I did NHS work for 10 years, I was a dumping ground for adhesive capsulitis. So I developed a deep disliking of and despair every time a patient with adhesive capsulitis came through the door. To be honest, I was only given 4 treatments by the NHS, in which to somehow miraculously make this patient better. And I was always sent to them when they were really in the frozen phase, so there was absolutely no chance of really improving them. I think you're right. It is overdiagnosed. I think true frozen shoulders when the person really can't actively or passively move the shoulder in any range of movement, and they are really limited in external rotation abduction. I tend to, depending on the patient, I tend to find, and the results are mixed, but I do tend to send them for hydrodilation injections, which are done in 2 stages to use a saline anesthetic. And I've watched it being done, and they can be very effective. They're not 100% guaranteed, but sometimes putting fluid in and fluffing up the joint capsule from the inside can be quite. I've seen some really miraculous ones, and I've seen some that haven't worked. So why they should work sometimes and not others is there's probably a lot of variables that contribute to that. But I think it depends on which phase you see it, and it can be a very difficult thing to treat. And I'm sure everyone else who's listening in or watching will agree with me on that one.
Yeah, they're very challenging, and they're very lengthy, and I mean, it's interesting because most of the frozen shoulders that I see, I probably see about 1 or 2 true frozen shoulders a year, so not very many. But I find most of my frozen shoulders actually come in, and they hit one of 2 categories. They're either post-traumatic, or like they've had a fall on a ski slope, or they've had a dislocation, and then they've ended up with frozen shoulder, or they're actually post-surgical. And Clive alluded to this just before on our last slide, that a lot of one of the biggest complications with shoulder surgery is the prevalence of frozen shoulder, or sometimes actually the shoulder surgeons often call it secondary stiffness. So it's essentially, imagine you're having a fairly invasive surgical procedure done, and then your arm is in a sling for, if you've had a rotator cuff tear and a repair, your arm could be in a sling for up to 6 weeks. Now, when you come to move your arm, it's the same as any joint. If you immobilize it for a specific length of time and then try and mobilize it again, the capsule's shrunk around the shoulder, and you come to move it, you've got a full-blown frozen shoulder. and that's a real problem. And it's very common after shoulder surgery, especially rotator cuff repair, because of the inflammation and the trauma from the surgery.
I think Simeon Neil Asher's had some great results with frozen shoulder. Obviously, he's developed a fairly worldwide reputation with his techniques. He's actually worked on my shoulder once at a conference, and I think he's doing really good work there, and it's got some very interesting ideas. He loves the long head of the biceps tendon as well as a contributing factor for impingement. So I think Simeon Neil Asher's work is definitely worth also using as part of our approach to shoulders.
Yeah, I'd agree with that. I watched him on the APM webinar it must have been about a few weeks ago, and he did a demonstration of his protocols for shoulder, for frozen shoulder. I thought it was really interesting, and he's obviously got loads of experience on it, so he's a great person to really look at for frozen shoulder. Okay.
If he was in England, I'd send all my patients to him with frozen shoulder.
Is he not in England? Where is he now?
No, he's mostly in Israel these days.
Oh, is he?
Yeah.
So for shoulder dislocation, I've just had a dislocated shoulder patient actually walk in with a dislocated shoulder on my treatment table, which was interesting. That happened about 6, 7, 8 weeks ago. Went to Croydon University Hospital, had an X-ray done, told him no fracture, sent home, came to my clinic, dropped shoulder, sent him for MRI, full dislocation, sent him back to the hospital, and had it relocated, and spent a couple of days in hospital, and he's still not right. This is something which fortunately we don't see too often. Actually, Clive, you've probably got some experience. Have you put one back in? I had one on a rugby field. I put him back in once. Have you?
No, I many years ago I worked with Dr. Ken Kingsbury, who was the sports doctor for the British judo team, and I saw shoulder dislocations, and I saw lots of thumbs and fingers. Well, these days you're advised not to try and put the shoulder back because of the potential brachial plexus injuries. So I haven't done them. I think I've seen many where they've been X-rayed only, and there was no Hill-Sachs lesion and no fracture. But I think an MRI scan is really necessary if you're going to pick up something like a Bankart lesion where you're getting glenoid labrum detachment and splitting, which you're not going to see on an X-ray. So, not all patients have insurance, so they don't have the luxury of being able to have a soft tissue imaging as well as a bony X-ray. But I think if you're relying on it only on an X-ray, then you really don't have any idea of the pathology, soft tissue pathology. And I've seen a number of cases where they've missed a Bankart lesion, and that's been the thing that stopped the patient recovering, and they've then had to go and have that further down the line actually surgically repaired. So I think if you can get an MRI, and they are affordable these days, then that's what I usually say to patients. Don't just rely on an X-ray. If you're seeing an orthopedic surgeon, they'll always do an MRI and an X-ray anyway. So that's my experience of dislocations. Yeah, I haven't put any back, and I'm not sure I dislocated my own shoulder. I'm not sure I want myself to do it.
Mine was
on incredibly painful.
Field. I was on a rugby field about 2002, 2003, and I'd newly qualified, and I was looking after the first team, and there was a game going on the other side of the fields, and I got called over. I could hear these yells going, "Tim, Tim!" So I bolted over to this other field. I saw this guy sitting on the side of a touchline, and he looked in a real sorry state, and he said, "I've done my shoulder." I said, "Oh no, I'll get you an ambulance." He said, "No, just put it back in." I said, "Not on your life." I said, "There's risk of nerve damage." He said, "I'm a police officer. Just put it back in. I trust. Just do it." So I didn't do anything. I just put his arm into external rotation, and it's just almighty crack. And then he was like, "This is great." And I said, "No, look, you need to go and see someone about this. So you're going to be sore a few weeks. But
yeah, of course.
That's
when people have recurrently with recurrent dislocations, they obviously learn how to put them back themselves. But I think you'll agree, if you have more than 3 dislocations, then you're probably looking at an orthopedic procedure to try and stabilize the shoulder if rehab is not going to be successful.
Yeah, and that's the thing. Once you dislocate the shoulder, you so very often take out the labrum, and it's a real problem, because then you lose the inherent stability of the shoulder. So however much rehab you do, and we'll talk about rehab for shoulder stability in a minute, but however much rehab you do, sometimes you just need to get the stabilization procedure. You used to call it a putty plat, didn't they? My father actually had one. God knows how long ago. Now what they do is they actually put two screws in and actually pull the capsule across and effectively sort of bolted onto each other. It's rarely done these days. I actually saw one a couple of years ago from our local shoulder surgeon. But the big problem is actually rehabilitating them and making sure that they're not left too stiff and not left too mobile. You've got to, when you rehab them, you want to get them at just the right range of movement, because some end up hypermobile again and some end up really stiff. So getting them in between is challenging.
It's a delicate balance between mobility and stability, isn't it? And that's one of the tricky parts about the rehabilitation.
Absolutely, it's a really delicate balance between mobility and stability, and it's because if they become too hypermobile with the shoulder, which is the risk, then the next, then you've got an unstable shoulder again.
Yeah.
Okay. So labral tears, I guess most people will be sort of familiar with a labral tear. There's lots of different types of labral tears, and depending on severity, I mean, in most cases, we simply just rehabilitate them. I say sort of rehabilitate them and hope they get better.
I think when patients have had a dislocation and they've not really had proper soft tissue investigation, and the shoulder is making, if you've got a lot of crepitus clicking and there's a lot of anterior-posterior glide, then I think you've got to be suspicious that perhaps a Bankart lesion, a labrum tear, has been missed, and you may need to go back to the diagnostic stage of things before you try and do further rehabilitation, particularly if they're not responding and still suffering pain.
Can you talk us through a little bit more about a Bankart lesion, Clive?
Well, I mean, basically, a Bankart lesion is a term for a labral tear. I don't remember, without referring to textbooks, which part of the labrum is more prone to tearing, whether it's anterior, posterior, or inferior. But essentially, if the glenohumeral joint actually dislocates, and obviously 90% of the time is an anterior dislocation, it will often take with it the cartilaginous labrum, and either partially or fully detach it. It's usually a partial detachment, because a full detachment means they really can't move the shoulder at all. Whereas a partial detachment can be quite difficult sometimes to pick up, and it does require soft tissue MRI imaging and sometimes an arthrogram to really show up the lesion.
Sometimes you can have a slap tear where the labrum sort of gets taken out. The biceps tendon.
Yes, exactly. Superior labral anterior posterior lesion, or known as slap lesions, they come in the categorization of 1 to 4. 1 would be just a bit of fraying of the labrum. 2 is a bit of partial detachment. 3 would be, from memory, a bucket handle tear, a bit like a meniscus labral tear, and then a 4 would be a full split of the labrum, and sometimes that involves the long head of the biceps as well, because that obviously attaches into the superior part, as you can see in that diagram that you've got up. You can see the long head of the biceps actually attaching to the superior part of the labrum, and a stage 4 slap tear would be a split of the labrum with the long head of the bicep tendon partially torn away from the labrum itself.
Good. So we've got biceps tendinopathy of the shoulder. So biceps tendinopathy, of course, can occur at the shoulder or at the elbow, and it's always an overuse injury. So we see this in people that are sporty, they might do weightlifting or they might do a repetitive sport. The tendon, can become degenerate or weak, and then becomes painful. And then you have this biceps tendinopathy. It's quite straightforward to treat with manual therapy, isn't it, Clive?
Well, it's quite accessible. I mean, it's often overlooked. We talk about the rotator cuff being stabilized. The long head of the bicep, if you look at the anatomy of where it attaches into the capsule and into the labrum, it's sort of, it's a very integral part of the musculature of the shoulder. Most of the ones I see are up in the upper glenohumeral end of the attachment. And I personally use a combination of soft tissue techniques, dry needling, acupuncture dry needling, and ultrasound, pulsed ultrasound as well. And then I give patients, home exercises, icing it, that sort of thing. Anti-inflammatory gels sometimes helpful as well, mostly because that patient will then massage themselves rather than the gel being helpful. But I see quite a lot of proximal bicipital tendinopathy.
Good. And then traumatic as well. We sometimes see the AC joint separation, where you have different classifications of separation. This is the Rockwood classification, and essentially it's different varying levels of multiple ligaments, potentially strain, tears, ruptures, and displacement of the clavicle.
Yeah, most rugby players have got one or both shoulders with the AC joint separation. They're quite difficult to treat. I find them really difficult, and even surgeons don't really like operating on them, particularly because the surgery is a bit like a spring. You're trying to force the spring back down, and once the acromioclavicular ligaments have ruptured, it's quite a difficult thing to fix. And actually, I see many patients, particularly ex-rugby players, contact sports, who've got AC joint separation, and they still have perfectly normal functioning shoulders. Obviously not ideal, but you've got enough functional movement there and other musculature to sort of, they don't look very nice, but you can function with an AC joint separation depending on, as you say, the classification of it, 1 to 4 or 5,
Absolutely.
even, or 6, depending on which literature you look at.
Now, when it comes to rehabilitation, there's a lot of different views on rehab, and I always say, if anyone heard me talking to Gilly this morning, I said the same thing, that when it comes to rehab, there's no clear protocol. It's very actually hard to find a research paper that actually will give you a clear protocol for doing shoulder rehabilitation or a particular pathology rehabilitation, like an impingement rehabilitation. So there's just simply concepts out there. There's lots of different concepts, from loading to improving posture, to improving range of movement, to kinetic chain, to scapular stabilization, to scapular retraction, to strengthening, to so there's different ideas and concepts, and there's not necessarily one correct way to rehabilitate a shoulder. A lot of it comes down to your own opinion and your own understanding of shoulders and your patient as well. And as I said this morning, it's very much with shoulders. We're not treating shoulder impingement. We're not rehabilitating shoulder, frozen shoulder. We're looking at Mrs. Jones and Mr. Smith and saying, look, what restrictions do they have? Some people have good movement, some have bad movement, some have weakness, some have poor posture, some have poor scapular dyskinesis, for example. And so it's really about identifying the what your patient has that we need to improve. And I know, Clive, you've got some experience with kinetic chains, for example. Can you share your experiences?
Yeah, I think, like you say, if it depends on the patient. There's lots of variables: their age, their expectations, their requirements. If it's just activities of daily living, you really want to have a good range of movement, and you can do some pretty basic rehabilitation. Home stuff for the older patients of bands and so forth, and just get them to improve. The scapula is really important. That's like the platform the shoulder works off. I think that's often undercooked. People don't do enough scapular control work. So in the older patient, you focus on rotator cuff and scapular control. I think if you're dealing with recreational athletes and then elite athletes, depending on the sport, you've got to really be much more holistic. I think you've got to look at the kinetic chain. And I had a very good example of I had a professional sportsman who had an inversion strain on the left ankle, and he was a tennis player. And the kinetic chain effect of that was that he had weakening as a consequence of the ankle injury. He had gluteal weakness. And then because of the myofascial connections and the Myers, if you look at the Myers textbook, of the opposite scapula being linked with the glute maximus and latissimus, he was effectively had poor subscapular control and dyskinesis, which was actually not local. It was a long way from the original injury, the shoulder injury. So sometimes in elite athletes, you've got to look at the whole body, which as osteopaths we're obviously taught to do anyway. And so in an elite athlete, your rehabilitation would be pretty extensive. It wouldn't just be about local pathology in the shoulder. You'd be looking at the entire kinetic chain. You'd be looking at everything from the foot upwards. And if you think that 50% of the power in the shoulder is generated from the lower extremity, if you don't have that efficient transfer of force from the lower extremity into the upper extremity via the scapula, then you're going to lose power. You're going to be more susceptible to injury. So I think, if the patient's got higher demands, you've really got to be pretty inventive with your rehabilitation and to really look at all the contributing factors. It depends on the patient, age, requirements. So obviously the rehabilitation for elite athletes can be very different from Mrs. Jones. So you've got to be very adaptive. But like you say, there's no single one protocol that fits every box. And I think if you've got a pretty good understanding of anatomy and rehabilitation, you can put together some pretty good comprehensive programs and do a good job on the person's recovery.
Yeah, I've actually created some protocols, Clive, for treating common shoulder problems for rehabilitating common shoulder problems like frozen shoulder and shoulder impingement. And I've got a phased, a week step and a phased approach, which I might just share with the viewers in a minute, just to give them an idea.
No, I think your Rehab My Patient stuff. As you know, we've used thousands of them. I think we're up to getting close to 5,000 patients, and it is fantastic because they're video based and because they are based on syndromes, and it really helps guide the patient on what they should be doing and shouldn't be doing. Anyone listening, or watching, I would urge you to use Rehab My Patient, because it's, in my experience, one of the best ones. It's not a hard sell on behalf of Tim, but I genuinely think it's giving people bits of paper just doesn't work these days, and his video-based protocols are excellent.
Yeah, good. So yeah, we'll definitely share some of those in a moment, Clive. So reading quite a lot of research papers about rehab of a shoulder, there's some things that really keep jumping out at me that I wanted to share with you. So the first tends to be that when you get a protracted shoulder or protracted shoulders or scapulae, in the case of people with rounded postures, you tend to get a narrow subacromial space. So posture, I think, is super important for rehabilitation and something we should look at long term. I'm just narrowing this down to the shoulder at the moment because, yes, of course, we always look at the rest of the body as well and see what's going on. I mean, poor posture is not necessarily a shoulder issue. It's often a thoracic kyphotic issue or a habitual postural issue. And so it's worth looking at all these other areas, and like Clive said, even going as far as the ankle, especially with an elite athlete, or when things. What I often do is when patients don't get better, I tend to look more holistically. So I tend to sort of start with the shoulder and then sort of work my way out if things are not getting better as quick as I'd expect. Because then I suddenly think, well, maybe there's something else going on that's impacting or predisposing this, and it might be thoracic spine, it might be neck, it might be something further down. Next thing is early stage rehab. There's lots of good support for passive range of movement exercises. So these are exercises where we're not putting the shoulder under too much load. We're supporting the shoulder and doing gentle exercises to improve range of movement. Interestingly, there's lots of research supporting loading the shoulder and strengthening the shoulder. So I think that's always a bit nerve-wracking for therapists to load a painful shoulder, but it's something that's well worth doing gently and within the patient's tolerance once they're able to, and once they get some movement back. And also, there does tend to be this inflammatory pattern with a lot of shoulder problems. And I think this is why a lot of GPs, I'm the same, I mean, I do the occasional shoulder injection, and they do often help. Now, there's pros and cons for injection, and this isn't the forum to discuss that, but you know, we do find that anti-inflammatories and injections and ice packs and this sort of thing does help reduce inflammation, it does help reduce pain, and it does tend to kickstart a rehabilitation process. So if we look at sort of how we can start to rehabilitate shoulders, you know, I think the first thing we tend to do is it's worthwhile giving advice. I think if once we've done an examination and we talk our patients and explain to them, you know, what the condition is, what the diagnosis is, you know, give them an advice sheet. On Rehab My Patient, we have like 470 advice sheets, and we have all these advice sheets. So you can give your patient an advice sheet quite easily, you know, explain to them, this is what I think is going wrong. And then I think your patient buys into it. And I think that starts the rehab process. That starts the understanding, it starts the acceptance. And that's what the first stage is. And advice as well, like talking to them about sleeping position. Lying on that side is often really, really difficult. And sometimes they have bilateral shoulder pain and can't lie on both sides. You have to explain about using pillows to prop them up and ways for them to manage the pain, because it's so painful that they need support, whether it be an ice pack or whether it be doing gentle exercises to help reduce inflammation, to stimulate blood flow, to gently improve range of movement. You know, we want to share advice, give them some support. I think that's the first step, and reduce inflammation. So if we can get that inflammation down, whatever way it is, it could be that they've seen their GP and they're now taking naproxen. It could be that they've come to see you and you do some gentle treatment. It might be whatever method to reduce inflammation, whether that be your own beliefs on, could be ultrasound or acupuncture or whatever belief you have to reduce inflammation, I think can be beneficial. And Clive, do you have any good ways to reduce inflammation?
Well, not everyone has access to Game Ready, but if you've got cryotherapy with a cuff, which we used at the Olympics, they were a fantastic way of reducing inflammation. Because as we know, if you have continued inflammation, it inhibits repair, and it's also going to start inhibiting muscle activity. So you're going to get arthrogenic muscle inhibition if you continue to have inflammation. So that, as you say, that's the first stage: reduce inflammation and reduce pain.
Yeah, and Game Readies are interesting devices. Actually, I do you remember actually when the Australian team borrowed one of our Game Readies from the polyclinic and never returned it?
Yeah,
they're in high demand from athletes. And yeah, you know, when we work at big events, actually one of the first things we do is we'll often just put an athlete on a Game Ready with any kind of acute trauma. It's just very, very accepted. And whatever your beliefs about whether ice reduces inflammation or reduces healing or whatever, it's a very accepted first line of treatment at major events. And this is all over the world. People, you know, therapists are using these approaches.
Yeah, I mean, the good thing is that there are competitive products out there apart from Game Ready, but it's a combination of pressure and icing, and the sort of therapeutic effect of that is quite dramatic, and certainly professional athletes really like it. Obviously, recreational athletes and the general public don't have access to that unless you have it in your clinic, of course, but they are quite expensive.
We actually have one in our clinic, Clive, and they are expensive. I mean, they're sort of pushing on 1,500, 2,000, and each cuff. Each cuff is sort of something like £300, so it's incredibly expensive. And I don't say we use ours that often because they are more for trauma. But
yeah,
we're quite lucky to have one. But they are good. There's other products out there as well, which can be used, which provide sort of this compression and icing. But the concept is reduce inflammation, and that can help reduce pain, and that can help our patients. So the next sort of thing we probably want to do is to start to look at their range of movement. Now, most shoulder problems typically present with stiffness and stiff shoulders. So we tend to find, especially with any sort of impingement, rotator cuff problem, we tend to find a loss of flexion, abduction, internal rotation. Obviously, if it's adhesive capsulitis, we tend to also find external rotations affected. And so I always believe one of the best things we can do is to start to engage with improving range. Now, the best way I find to do that is to do passive exercises. Now, why does this help? Well, first of all, moving a joint is really good to reduce inflammation. You know what it's like. You go to bed at night, you wake up and you're sore the next morning because inflammation tends to build up when you're less mobile, right? That's very accepted. So we know that moving tends to help with pain. And I think that's because it helps with the fluid dynamics and it helps to disperse inflammation. And these are simple exercises that you can prescribe to your patients that we'll go into some more detail in this in a minute, but these are simple exercises you can do to straight away help disperse inflammation and to help to reduce pain. Gentle mobility exercises. They're great to do. They're easy. You know, the rock the baby is a really easy one to explain. And so we can start to improve range of movement. We also want to put stability into the shoulder as well. So stability could be inherent glenohumeral joint stability, or it could be scapular stability. And both are important. Stability should never be forgotten because any joint needs that inherent stability. Now, often that's provided by the ligaments around a joint or the small muscles such as rotator cuff muscles. But building stability to a joint is I always believe, the first stage to building strength. When you have a stable joint, you can then have strength from the muscles that move from that stability. I always describe the analogy of using a Smith machine. So you imagine a Smith machine's a big sort of metal frame gym equipment. You lie down on a bench and you pump the bar up and down, and it's like a bar that's designed for stability. So you can put massive load of weights on it. You can really ramp up the weights. And if you destabilize, so if you take away the Smith machine and just use a bar, you can't lift anywhere near as heavy. And if you destabilize again and use dumbbells, you have to reduce the weight because you've lost stability, so you lose strength. If you destabilize it again and lie on a Swiss ball and do a bench press, you're less stable, so you're less strong. And I think that's why it's so useful to build up the stability in the shoulder. And then, of course, yeah.
Sorry, Tim, I was just going to add just quickly the range of movement. We shouldn't forget the thoracic spine because obviously there's coupled motion between the thoracic spine and the glenohumeral joint. So part of the increasing the range of movement is also looking at the thoracic spine and giving people usually extension exercises to try and mobilize the thoracic spine and make sure you haven't got too many joint restrictions there. So I think that's another thing to look at.
Yeah, I mean, you're so right, and especially we see sort of shoulder flexion really coupled with thoracic extension, and it's so important for posture, isn't it? So if we look at some of our extension-based exercises, this sort of thing is so useful to help improve extension or help to improve thoracic mobility. This is our very, very commonly used and traditional osteopathic figure of 8 thoracic mobilization, which is a fantastic way. They may not even be able to get their shoulders up to that point, so they can cross their shoulders across their arms if they can't. Have you got any other thoracic sort of exercises that you like to
no, I tend to be honest, I tend to use yours, but I like just simple things like rolled up bath towel and extension exercises. Again, obviously the shoulder may not be able to move very far, but you try and get as much movement as you can in the thoracic spine without upsetting the shoulder joint itself. The other thing I was going to say, you're probably going to touch on this, but proprioceptive training is so important because very often the Golgi tendon organs, the receptors, mechanoreceptors in the joint capsules and the ligaments, they've lost a lot of their proprioceptive ability. So you do need to add, and there you have an example there, of proprioceptive training where you're challenging the joint and activating this afferent control, which is going to have a improved sort of spatial and motor control. Again, in elite sports, you'd obviously focus on that a lot more and make it very sport specific.
Yeah, absolutely. Now we find a lot of good proprioception stuff you can do on all fours, for example. You can weight shift on all fours. So you can just start to load one shoulder. You can, and it's so important to regain that neurological control and stability of the joint. Especially after trauma, you lose so much of that neurological and proprioceptive control of the joint, and so shoulder injuries are more prevalent again. You're more likely to injure it because you've lost that neurological proprioception. And so these sort of shoulder exercises, they might look very, very simple and very, very straightforward, but actually they're really important. And this sort of being on one arm, one leg, this sort of horse stance, bird dog type fire, sometimes some people call it a fire hydrant type exercises is very good. Also things like wall press ups are good. Any kind of press up on a, so here's a kneeling press up on a ball with one hand, and obviously the ball is unstable, so you can start to just put very small movements through the shoulder to help build up that proprioception. Now, let's look at some passive range of movement exercises as well. So some of mine, I love the rock the baby because it's a passive shoulder mobilization in abduction. So you can support the arm while you move the other arm. And there's lots of passive exercises. The other commonly used ones are the passive arm lifts. So you're just simply going to support the arm and lift the shoulder, use a good arm to lift the bad arm. These are all good exercises. You can also use dowel rods as well. So you can, with a dowel rod, you can sort of assist with. Now, none of these exercises are completely passive, right? There's some small muscle activation, of course, because you're not anesthetized, but there's as close to passive as you can get, and they help mobilize the shoulder without putting too much sort of pressure through the shoulder. So for early acute shoulders, this can be very, very useful with a passive mobilization, such as here's another passive abduction exercise. And then sort of once we get the range of movement back, then we want to look at things like scapular stability as well. So scapular stability is often closely related to scapular retraction. And things that improve scapular retraction are anything where we tend to draw the shoulder blades medially or inwards. They're very simple to do. They can be as simple as simply just sitting there and just literally just drawing contracting your shoulder blades inwards, contracting your rhomboid muscles and mid trapezius to activate those scapular muscles. They're generally weakened, they're generally stretched because of rounded posture, and so strengthening those can definitely help with both posture and shoulder pain.
I think for patients who don't, for practitioners who are not familiar with Rehab My Patient, under each diagram is a video link, and that really helps patients to be able to visualize it. Yeah, you've clicked on that now. Yeah, because particularly in the NHS, they seem to give out lots of exercise on bits of paper. Apart from the fact it's uninspiring, it's also patients get very confused, and I think the video-based exercises are fantastic, and the feedback we get from patients are that it's they really love it to be able to visually see what they've got to do. Makes a big difference.
Yeah, absolutely. It's when we prescribe exercise, you know, we want to like demonstrate the exercise. We want to put a description, a picture. It might not be you don't like the pictures, you want to do line arts. And it's about making this as visual as possible, because people learn well visually, and videos help people to adhere. And good adherence means patients probably improve, and patients are, it makes our job easier. It means we probably, for complicated shoulder problems where you might spend a lot of time on them, you know, it helps speed up rehabilitation, and it just benefits everybody. Now, strengthening exercises, typically a lot of people talk about TheraBand exercises, Clive, and we've got quite a few TheraBand exercises here. I'm not sure about yourself, but I quite like prescribing TheraBand exercises, and I find them very...
I think they're fantastic, because a lot of people don't have access to a gym and access to cable machines and things like that. Also, you know, if you're traveling abroad, if you're going on holiday, you know, they don't take up any space, and so they're very useful addition. Also, they are sort of functional, because there's an element of there's quite a lot of proprioceptive required, control required, and you can do lots of weird and wonderful exercises. And obviously, on your program, you've got a lot of different muscle groups that you can target very specifically. So, yeah, I'm a big fan of TheraBand, Dynabands, whatever you want to call them, and they all come in different colors, different strengths, so you can have a good progression as well. And patients like the feel of them, and they say you can do it anywhere in the house as long as you can tie it to something. So they're very accessible and really useful addition to rehabilitation.
I completely agree. I love prescribing TheraBand exercises at that point of rehabilitation, because I just find patients just get it. You know, they understand it, they get it. It's easy to use. It's easy. We sell TheraBands. I don't know about you. I mean, we charge £4 for a strip of TheraBand. So we buy them in the rolls. They're sort of 30, 40 quid a roll. We sell them for £4 a couple of yards for £4. And patients just completely, they get it. You know.
It's cheap rehabilitation for them, and you know, one of your diagrams just now showed a shoulder exercise with the arm above the head, the ascended 120 degrees internal rotation. You can make the exercises really specific. So for a tennis player, for example, if you want to rehabilitate them, you know, properly, you've got that exercise. Yeah, that would be a brilliant exercise, which would sort of mimic and be very sport specific. So it does give you that ability, as a result of using bands, to really make the exercises very, very targeted. So there you've got an example there. So you know, if you're a javelin thrower, you know, that might be a very helpful exercise. So I like them.
Yeah, this comes on nicely to the last stage of rehab, actually, which is we want to prepare our patients to get back onto the playing field, don't we? Whatever it may be. I mean, it may be that they want to get back into swimming or sport or golf, or it may just be they want to be able to walk comfortably. But functional rehabilitation is generally sort of is how we can get them prepared for sport. Now, Clive, you are a real pro on functional rehabilitation, and can you share some nuggets of... You've already shared one.
I don't think I'm a pro on it. I don't think I'm pro because I have 3 physios working for me, so I tend to push them their way. But I think what's really important, and when you talk about functional stability, you're really wanting to have, you know, functional mobility and stability. So you want a full range of movement, and you want good muscle co-activation, and you want to make sure that every aspect of the kinetic chain is functioning properly for force transfer, and to be able to dissociate joints. So in other words, you can move it in isolation with a controlled motion. So yeah, I mean, you know, obviously there are a huge variety of sports. For example, if you're a swimmer, you know, they get a lot of impingement syndromes. If you do a 10-kilometer swim, you might have 4,000 revolutions of a shoulder joint. So if you don't have good muscle co-activation and that glenohumeral joint's not sitting in a nice neutral position, and you've got uncontrolled translation, you know, it's not difficult to see how you're going to end up with pathology at the end of it. So the rehabilitation is really, really important, and it doesn't matter what sport you're involved in, you've got to be able to cross-train. I think what's really important is not just doing the rehabilitation short term, you've got to think of it as a long-term strategy for injury prevention. So I think this is missed quite often. Someone has an injury, they do rehabilitation for a period of time, and then they just go back to their old ways. I think you've got to be thinking of making sure you're doing compensatory movements, to make sure that you don't get a recurrence of injury. So I think that's where rehabilitation can be ongoing, and it doesn't have to be a big chore. It can be part of your training process, just making sure you're doing exercises which reduce the chance of you getting a recurrence of the injury, which is obviously, very important for many reasons.
Amazing. Fantastic, Clive. Is there anything else you want to share? I'll just check if there's any questions coming up before we finish. If you need to contact Clive, here's his contact details here: clive@putneyclinic.co.uk. I'm on Twitter if you need to contact me.
I'm on Twitter, but I never look at it. I've got 3 followers: my son, my daughter, and my wife.
I need to follow you then and be number 4. Yeah, so feel free to drop us a line if you want any more information. Anything else you want to share with us, Clive, with regards to rehab or functional rehab?
No, I think I think you've been pretty comprehensive. We've got to be flexible to deal with people in non-sports community, and to be aware of. I think in the sporting community, I think it's really helpful to have an understanding of the sport, so you understand the biomechanics and the loading and the likelihood of injuries. And my personal interest these days is more triathlon, because I like the predictability of the injuries in many respects. So I think a good understanding of the sport you're dealing with, coupled with what sort of rehabilitation is appropriate. But the good thing about rehabilitation, you can provide it for everybody to some degree and some level. You just have to have an adaptability about it.
Quick question from someone: why do some new mothers develop shoulder pain shortly after giving birth?
I see quite a lot of women with that, and I'm pretty sure it's obviously non-traumatic. It's accumulative, and it's probably a postural change during pregnancy. Also, you've got to factor in that there's ligament softening, and I don't like to use the word instability, but there is a loss of core control further down the kinetic chain, in the particularly pelvis and lumbar spine. So there's bound to be compensatory muscle activity higher up the kinetic chain, coupled with the fact that they tend to be breastfeeding, so that patients are often or women are in these flex postures, and they do get a lot of neck and shoulder syndromes. I think breastfeeding is a big part of it, and I found those sort of devices that they can wear. My sister used to live in America, and she used to. There was a kind of whole strap-on device that you could wear that took a lot of loading off the neck and shoulder and did help. So I think that's probably why they get, why women get that in, after giving birth.
Yeah, and a bit later down the line, I find as well carrying those. We've actually just started shooting a paediatric section, and I carried in little baby Dylan, who we've got an amazing osteopath called Neve, and she's given birth not long ago, and I carried him on that baby cat. Oh my goodness, the car seats are so heavy. They put such load through your back and neck and shoulder. I mean, it's so
it's
much
not until you have your
stress.
own it's not until you have your own children you realize why so many particularly women suffer after pregnancy. The day-to-day ergonomics of cots and buggies and car seats, it's a big problem. That's a whole subject of rehabilitation on its own.
Absolutely. Okay, Clive, I think we should wrap it up there.
Okay, thanks, Tim. Sorry everyone that I couldn't be visual.
I'd just like to say a big thank you to Tim and Clive, and thanks for what was a fascinating webinar and for sharing your experiences. For delegates, if you need to, the video will be available as well to review. So if there are any elements that you missed and you want to rewatch, then please do. Otherwise, yeah, thank you very much, guys, and enjoy the bank holiday weekend to everybody.
Yeah,
thanks a lot.
Thank you very much. Good luck to everyone getting restarted.
Yeah,
thank you.
Bye.
Thank you. Bye.